Hello everybody and welcome to this month's version of IMV Imaging's Journal Club. Today's episode is presented by me. I'm Jake. I'm one of the newer members of the clinical team here at IMV. So it's nice to meet you all, and I'm sure I'll meet again on future episodes of Journal Club 2. Hopefully a few of you are sort of regular members of our Journal Club here. It's nice to welcome you back. Those of you that it's your first time, welcome. As with all of these episodes that we put out, we would encourage, if there are any questions relating to the paper that we discuss, to pop them in the Q&A box or send us your questions via email to our clinical email address here on the screen. This information will pop up again at the end, so if you do miss that, you can grab our email at a later point, and yeah, please do send in questions, because it's great to interact if there are any thoughts or differing opinions on these papers. So today's paper, the paper I've chosen was published in JSAP. It is a paper looking at the accuracy and reliability of tele-ultrasonography in detecting gastrointestinal obstruction in dogs and cats. Just a bit of background with what that sort of is discussing. I think most of us who've worked in any small animal first opinion practice will be familiar with the gastrointestinal mechanical obstruction. These are sort of fairly common surgical emergencies that we'll be presented with. It's quite commonplace for either one or both of abdominal radiography or abdominal ultrasound to be used as a diagnostic tool in these cases. I think most people will reach to radiography first, but ultrasound is also very useful, and it can allow a much more accurate diagnosis of location of the obstruction as well. I think it goes without saying there's some obvious drawbacks with ultrasound. Is a bit more variability really in operator skill set, and also machine availability or quality, which again will all impact how useful imaging modality that presents to you in practice. Just moving on. A bit of discussion about tele-ultrasonography, which in the paper is referred to under the abbreviation of TUS. Teleradiography is probably a word we're more familiar with than tele-ultrasonography. Teleradiography would relate to the transfer of digital images via the internet for interpretation and a report to be produced and then sent back to us. This is widespread in both human and veterinary medicine. I think we're all quite used to sending off CT images for interpretation elsewhere and then a report being sent back to us. I think a sort of a subset of teleradiography really would be tele-ultrasonography, which is something that is used in human medicine, but there's much less literature and use of it so far in veterinary medicine. I think a big part of that seems to come down to the fact that there's no sort of standardized views when it comes to performing sort of abdominal ultrasound or investigation for, say, foreign body hair. So the paper that I've chosen here chose their study aim to assess the accuracy and inter-observer agreement of tele-ultrasonography for the diagnosis of gastrointestinal obstruction in small animals by radiologists with different levels of experience. It's a bit of a mouthful. Their hypothesis was that tele-ultrasonography had high accuracy and inter-observer agreement for the diagnosis of GI obstruction in dogs and cats for observers with different levels of experience. So we'll move on to the study design and a bit of methods. So it was a retrospective cross-sectional study using tele-ultrasonography. The images were collected between the dates here, January the 27th in 2017 through to December in 2019. The imaging records were from a veterinary teaching hospital that were used in this study, and all of the original ultrasound images were obtained by residents that had at least 6 months of experience within diagnostic imaging and ultrasound. Over that time period, they had 4 different residents and 3 different machines used to collect the images and cine loops that were used as part of this study. Unfortunately, they weren't able, with the DICOM images that they had, to differentiate between those residents. Is one of the things they highlighted there. And there was no standard as to what images were obtained, and some animal data sets were incomplete. They had images or cine loops missing. The authors did decide that they would still include those with incomplete data sets, as they also thought it would be interesting to assess whether having an incomplete data set would influence the observer's ability to interpret those images and give their opinion on a diagnosis, and how accurate they would be at diagnosing with an incomplete data set. So they drew up some inclusion criteria and exclusion criteria. So the inclusion criteria were dogs and cats that had GI signs, so vomiting, diarrhea, acute abdomen, etc., or any dog or cat with a clinical suspicion of mechanical obstruction, or both. Patients also had to have had abdominal ultrasound exams performed with DICOM images saved for review. The exclusion criteria were patients that had less than 10 ultrasound images or cine loops in their medical file, any patients that had undergone recent GI surgery, or patients that had ultrasound signs of obstruction, but then weren't confirmed either surgically to have the obstruction, endoscopically to prove there was an obstruction, or by a necropsy, again to prove that the obstruction that was seen was there. So this way they kind of worked through this. Initially, they had nearly 350 dogs and cats that would meet their inclusion criteria. This number was deemed too many for the study. So they used a computer program to reduce that number with a stratified random sampling technique, and that sample size was reduced down to 132 patients that went through the inclusion and exclusion criteria. The 42 of those animals were then excluded because they had less than 10 images on their file, or they never went to surgery or had endoscopy or necropsy to prove the presence of the foreign body that was found. So there were 90 animals left for analysis in this study. The 90 animals that were included were then split into 2 groups, and this was based on their medical record data, so the outcomes for these cases, being that this study is retrospective, the sort of animal outcomes were already known. So group 1 were animals that had a partial or complete GI obstruction confirmed on those records, or group 2 were those animals that after imaging were proven to have no obstruction, either through surgery or showing on their medical record that they recovered and got back to good health without the requirement for that. So on to the next slide. This just talks a bit about the observers that were used in the study. So they had 4 different observers to assess each of these cases. Observer 1 was a board certified diplomat of the American College of Veterinary Radiology and the European College of Veterinary Diagnostic Imaging. This person had 22 years of experience. Observer 2 was a veterinary radiologist with 12 years of experience. Observer 3 was a radiologist with 4 years of experience. And finally, Observer 4 was a first-year veterinary radiology resident. Each of the observers were given 16 patients a week with a bit of background history, but they weren't able to view the case outcomes. Their history that they were given were the parts up at the time of presentation up until the imaging was performed, but they had no idea whether these cases ended up going to surgery, etc. The observers were asked to review the images and write a report. As part of that report, they had to describe any ultrasound signs of GI obstruction, if they could see any signs of that present. They were also asked if they thought there was an obstruction, what they thought the cause was. And finally, would they recommend exploratory laparotomy for that patient? So these were sort of questions that they were asked. So the descriptive analysis, this is the information that's known by the person writing the study, where they had the medical records. So of the 90 animals included in the study, 69 rather of those were dogs. 20 of those dogs had GI obstructions. They would form into that group 1, which had been confirmed at surgery, endoscopically, or by necropsy. 21 of the 90 animals were cats. 3 of these cats had GI obstruction, again confirmed with surgery, endoscopically, or at necropsy. The outcomes of these cases, which were shown in the medical records, was used as the gold standard answer that they were going to compare the observers' results against. So the observers were all sent a series of ultrasound images and cine files as well, so sort of cine loops. This is just a couple of examples of some of the images that were included in the study. The one on the left was a young cat that fell into group 1, so had a linear intestinal foreign body that all observers were able to correctly identify, which you can see in the image there on the left. Image B was a 15-year-old cat who had some shadowing of food ingesta within the stomach, and they were classified as obstructed by 2 observers. However, the medical data records showed that that patient actually was found to have cardia thickening, but no obstruction, because this animal did go through surgery. So the results to this study, they can kind of be broken down into 3 parts. I think it makes it easier to interpret if we do. Part 1 was them looking at the specificity, the sensitivity, the positive predictive value, the negative predictive value, and accuracy of each observer across the case they were given, which we'll go on to next. Part 2 was looking at whether the subjective assessment by each of the observers as to whether they felt there was sufficient or insufficient data sets or numbers of images to be able to make a diagnosis had any association with how likely they were to get the correct diagnosis. And then part 3 were looking at the inter-observer agreement, and they used Felice's Kappa score to decide how good the inter-observer agreement was. So these are the results that relate to the specificity, sensitivity, positive predictive value, negative predictive value, and accuracy for each observer. The table is quite data heavy there, but the left-hand side is for each observer for all animals, each of those percentages. Then on the right-hand side, they've broken that down into dogs and cats separately. I will just bring that into a slightly easier to digest format on the next slide. So interpreting those images by the different observers showed intervals of accuracy ranging between 78.9% to 87.8% across the different observers. We had a sensitivity interval of 73.9% to 100%, again across all 4. Specificity was ranging between 77.6 and 89.6. Positive predictive value ranged between 55.9 and 70%. And the negative predictive value ranging between 90.9 to 100%. So while that's all useful data, in terms of what that would mean from a clinical perspective, the most probably useful number there for bringing this into clinical relevance would be the positive predictive value. That would be because if we were using this as a tele-ultrasonography service, this would be of the results that come back as positive from this test. So that would be including true positives and false positives. What percentage of those are your true positives? And obviously, if the outcome of what the tele-ultrasonography service showed led to helping you make a decision on whether this was going to be an animal that would undergo surgery, we'd want this positive predictive value to be as high as possible, so as few false positives as is possible. So in this study, that positive predictive value ranged from 55.9 to 70.8%. So at that number there shows a reasonable number of false positives present, which obviously from a clinical outcome is not so ideal. Well, not surprisingly, really, the board certified observer that had sort of the most experience also had the highest specificity and positive predictive value, whereas the resident who was on the least and lower end of the experience had the lowest specificity and positive predictive value, which I think we would expect. But I think, yeah, it's just interesting that they've been able to demonstrate that too. Part 2 of these results, so this is the part where they were looking at the subjective assessment of each observer as to whether they felt the data set of images that were available were sufficient enough that they could make a diagnosis, and what association that subjective assessment had against whether they actually got the correct diagnoses. So again, this is it presented in table form, but to summarize that table, they showed there was no statistical significance in terms of association between the number of correct and incorrect detections of obstruction and the subjective adequacy of the amount of images available for the tele-ultrasound service. That is except for observer 4, who was the first year resident, who had a higher rate of correct diagnoses of obstruction when they deemed the imaging material provided to be sufficient versus when they thought it was insufficient. So then part 3, this was looking at the inter-observer agreement, sort of on a case-by-case basis, and they measured this using Fleece's kappa measurements. They have a range of intervals of agreements which were defined here and they're shown on screen. Obviously, we'd want a tele-ultrasonography service to be providing almost perfect inter-observer agreements, as the author of the study showed as well. That's what they were wanting. However, the results from this study gave a score as 0.6, which would put them at the lower end of the moderate level of agreement, which, yeah, again, is not ideal. Sort of looking at this study in terms of any limitations, I think there's a few things that the authors flagged up, and I've sort of flagged up here too. So it is a retrospective study, so there was no standardization in terms of what image sets were going to be obtained for the study. So obviously, if it's prospective, they could have set certain lengths of cine files to save, or certain standardized view of any areas of interest, etc. There were also large differences in the number of dogs versus cats used in the study. Another thing to bear in mind would be that the difference between sort of field and laboratory bias. So these observers knew that regardless of what decision they came to, there wasn't any clinical consequence at the end of their decision making. So if they said, yes, I think there's a foreign body present or an obstruction here, it didn't mean that that animal was then selected for surgery. It was just their outcome was compared to the case's outcome that was already known. Whereas obviously that if they were weighing up what decision they make against, okay, this animal is about to go into surgery. If I say yes or no, that could give a different outcome for these observers. There were also a very small number of observers used, and one of them being very much lower in experience level, which again will impact the data, which you can see on those tables higher in this presentation. There was also the inclusion of these incomplete data sets, which seemed to be added as kind of a later thought to the study, but not that it necessarily brought anything negative. It seemed to sort of complicate the study a little bit. I don't think it necessarily needed to be involved in this study today. Moving on, so clinical relevance. We've discussed a bit of this as we went through the results, but just to kind of summarize and bring this all together, I think in short, this paper would say that tele-ultrasonography is not yet a reliable enough way to assess patients with GI obstruction and make decisions on whether they would be appropriate surgical candidates or not. I think the rate, the rate of false positives and also the variable inter-observer agreement were not good enough yet for this to be used as a basis to roll this out onto a larger scale, particularly because patients undergoing unnecessary surgery comes with substantial risks. I think this highlights an interesting area of further research, and I think there's definitely room for further work here. But yeah, that's it for today's paper. I hope you've all enjoyed listening and following along. If you do have any questions, please do get in touch either by email or popping your questions in the Q&A box below. And yeah, we'll look forward to interacting with anybody that has any differing thoughts or opinions. Otherwise, that's it from me today. And I guess take care, and we'll see you next month at the next Journal Club. Okay, bye-bye.